Hello, I'm Sarah Hadfield. I'm a GP in North Devon, and I've got a slightly unusual interest in mind-body medicine, which is basically about understanding how stress and emotions and psychological processes have a big impact on physical health and what we can do about it. So over the past few years, I've been training kind of outside of medicine, learning different psychological and emotional techniques so that I can do this work with patients. So that brings me to my declarations. I've run a small private practice for the past 2 years doing this work, and I'm really enjoying it. I don't really want to do it privately, but there isn't any scope for this in the NHS at the moment. I am working with other doctors in the UK, trying to work out how we could integrate this into an NHS service. So hopefully it will come. And also, because I've only been doing it for a couple of years and by no means an expert, I am still training and learning as I go along, and hoping to share with you today some of the things I've learned so far. So thank you so much to Fiona. Hers is such an amazing and inspiring story. It just shows you what can happen when you shift the focus away from that purely physical approach to symptoms. And there are thousands of recovery stories like Fiona's out there, so really exciting and encouraging. And thank you to you in the audience for tuning in. I'm going to try and keep it simple, but I have packed quite a lot in. I've provided some handouts for you, which have lots of links and lots of information. So hopefully most of what you see in the slides will be there for you to look at later. So what am I actually talking about? How does this connection between mind and body actually produce symptoms? And it's estimated that about 40% of what presents to a GP each day is medically unexplained. So there's clearly a great need to understand this better and find more effective treatments. And there are many examples of the mind-body connection in everyday life that we just don't pay that much attention to, such as crying when we feel sad or blushing when we feel embarrassed. And it's fairly obvious that the brain and the nervous system are really central to these processes, but they're not just happening during occasional emotional upsets. This is a continuous process of mind affecting body. And those kind of more non-conscious effects, that we're not aware of, like changes in heart rate, breathing, digestive function, immune system function, muscle tension, they're all happening all the time. And over time, they can build up into really real physical symptoms. I want to touch briefly here on the language that we use to discuss these issues. So for the sake of the presentation today, I'm going to call them mind-body symptoms, but they're also known as functional illnesses, disorders, medically unexplained symptoms, psychosomatic symptoms, psychophysiologic disorders, PPD, this is the American term, stress-induced symptoms, or neural pathway, neuroplastic disorders, and probably many more. And this really illustrates one of the difficulties we have when communicating with colleagues, because we're using lots of different terms to explain probably the same thing. So what are mind-body symptoms? And first and foremost, I want to really emphasize that they are real. And I really can't emphasize this enough. They're not all in your head. They're not made up. They're not imagined. They're not a mental illness. And they're not an excuse at all. They are actual real physical symptoms that are manifesting in the body. Diarrhea, whether it's caused by gastroenteritis or a learned response to stress, is just the same debilitating and distressing experience, perhaps more so if it's stress-related, as the message is often that we don't really know why it's happening, or we don't really know how to treat it for many people. Number two, they are a physical manifestation of chronic psychological stress. And as we know, stress can take many different forms. And the kind of stress that causes persistent physical symptoms, it builds up over time, and often it's completely out of conscious awareness. So the task is to help patients understand where all these different stresses are coming from, and they may not be aware of them at all. So we look at kind of obvious current stressful events, paying particular attention to any events that trigger symptoms. Also looking at past events, so their past experience of stress, paying particular attention to adverse childhood experiences. And I haven't really got time today to go into the research on ACEs, and the effect they have on physical health. But there's been a lot of research over the past 20 years, and I've put links to this in the handout. And then there's self-induced pressures, which are personality traits such as self-criticism, people-pleasing, perfectionism. Actually, they're personality traits that are often quite common amongst GPs. And these traits, they increase our internal stress levels, and they often feel so normal to us that we barely notice them at all, and we don't realise how much extra stress is being generated internally by them. And then there's psychological stress. And some parts of the brain can find it really difficult to distinguish between what's imagined and what's real. I'll just do a really brief experiential exercise if you'd like to join in. So if you just shut your eyes and imagine that you can see a lemon, really imagine the colour and the texture. And imagine taking a knife, cutting it in two, smelling the citrus spray and seeing the juice. And then taking one of the cut edges of that lemon and putting it right in your tongue and squeezing the juice into your mouth. And most people, when they go through that, will notice some changes in their mouth as they imagine that. And seeing this image as you open your eyes should really seal the deal. And that's just things that we can imagine can cause a very real physical response. Replaying or imagining stressful events, just as or even just watching the news, can really trigger this physiological stress response and keep it very active. And then there's emotional stress. And we often see emotions more in the context of mental health and physical health, but each emotion has a really clear physiological pattern in the body, often preparing the body to act in some way, such as anger causing muscle tension in the arms and clenching in the jaw, ready to fight and defend. So some strong emotions can therefore be really physically overwhelming, especially for children, and especially if there isn't a safe adult around to comfort the child and to help them to process the emotion and calm down. So in essence, the emotions themselves, especially negative ones, can then become threatening. And as they arise in the body throughout the lifetime, they're then kind of repressed and resisted, and that it causes a lot of internal stress and a lot of fatigue. Number 3, they are caused by neural pathway changes in the brain. So I'm going to explain this in very basic terms, kind of how I'd explain it to a patient. So I'm hoping there's no neuroscientists in the audience. So we get some tissue injury of some sort, which sends signals to the brain of tissue damage, and then the brain interprets those signals and decides what the threat level is. And if danger is perceived, then nerves are activated to elicit a physical response to protect the body and to start repairing from any injury. And these are things such as pain, muscle tension and contraction, elevated heart rate, inflammation, anxiety, and other symptoms. And essentially, the brain produces 100% of all of our physical sensations. And it also can alter the function of every organ and every system in the body. So it can pretty much produce any symptom anywhere. And the problem is that once these pathways are created, they can then be reactivated by the brain itself as part of its protective response to threat. So any conscious or unconscious stress can drive up that threat level and trigger the pathways. And as well as that, you've got the kind of cascade of the physiological stress response also having an effect on the body. And these pathways can become very sensitive, like a car alarm that goes off like every time a leaf falls on the roof or something like that. And the more the pathway is activated, the more persistent the symptoms become. The brain actually learns how to produce the symptoms, and they become a conditioned response to certain triggers. And in addition to all of this, there's also the fear of the symptoms themselves and what they might mean for the person. So there's the fear of the pain, fear of death, fear of disability. It goes on. And the more fear there is, the more attention gets focused on the symptoms and the more the pathway gets reinforced. And unfortunately, this is where the typical medical response to these symptoms can increase the sense of danger and actually make the symptoms worse. And I'll talk a bit later about what I think we can do to alleviate this. But the good news is that because the brain is so highly plastic, if we're dealing with a symptom that's caused by an overactive active neural pathway, then the symptoms can be resolved by doing stress reduction and neural reprogramming without any physical intervention at all. And number 4, they can affect any organ or system in the body. So there's a list here, and that's also in your handouts, of the conditions that are commonly have a significant contribution from mind-body processes. Obviously, organic processes can cause any of these as well, so it's important to exclude those. But it just shows you how wide-ranging they are. And 5, they are not caused by organic or structural problems in the body. So that's not to say there'll be a complete absence of physical signs, because as we said before, there's some of the neural pathway effects may be muscle tension or inflammation, or really, like I said, any symptom in the body. So it's more that the actual cause of them isn't coming from a pathological process or disease process in the body. So it's important to help patients understand this and not to falsely attribute incidental physical findings to the symptoms. So I'm just going to give the example of back pain, which we see a lot of, and it's often the pain is attributed to abnormalities on MRI scans. But this large systematic review from 2015 showed that many of these abnormalities are actually normal age-related changes. So this is looking at people without any pain whatsoever. In their 20s, 37% will actually have disc degeneration, 30% bulging discs. 96% in their 80s have disc degeneration with no pain, 84% bulging discs. So the problem with telling someone with neural pathway pain that they have a spinal abnormality is that it increases the fear and it reinforces the pathway. So it's really important that we learn how to make a positive diagnosis of a mind-body disorder. The patient can then be offered an explanation, they can have the chance of effective treatment, and we can also reduce the risk of harm from unnecessary investigations and invasive physical treatments. And it is possible to make a diagnosis if you know what you're looking for. As I mentioned at the start, I am by no means an expert in the field yet, but there are lots of experts out there. There's Georgie Oldfield in the UK, and she's a physiotherapist who's been doing this work for years and now trains healthcare professionals in the UK with her organisation SERPA. And in America, there's some physician experts and other healthcare professionals, but there's physician experts who've treated thousands of patients successfully. And they've put together the Psychophysiologic Disorders Association. And they've developed some guidelines for making a diagnosis. So first of all, rule out a structural organic disease process. Obviously, we don't want to miss anything that needs to be medically treated. And then 2 is to rule in a mind-body disorder. And Dr. Howard Schubiner has developed some criteria for this, the FIT criteria. So F is for functional. Symptoms do not fit with or are not explainable by known structural conditions. So this is symptoms such as those that occur on one whole side of the body or occur in many different body locations at the same time. Then it's inconsistent. Symptoms vary in ways that a structural condition would not. So this is maybe symptoms that occur after but not during activity, or get worse when you think about them. And then T is for triggered. Symptoms are brought on by stimuli that would not actually cause the symptom physically, but they activate the brain to generate the symptom. So symptoms triggered by unrelated things such as food, light, cold weather. And please look at the handout because I've put much more detail into these criteria there, and there's more examples that will make them help them to make more sense. And that brings us to treatment. Effective evidence-based treatments are available. And to be clear, it's not expected that GPs would actually provide these treatments. I personally have gone into the more therapeutic side of mind-body medicine, but it's not something that's really that possible within 10-minute consultation. So I'll just go through the basic treatment principles, education. So once a positive diagnosis is made, then we can explain that symptoms are due to a stressed out nervous system and not due to a disease, and that they can resolve with non-physical treatments. And obviously, after a lifetime of learning otherwise, that education process can take some time with some people. Stress awareness and reduction. So this is helping people to make those links between stress and their symptoms and bringing the focus back to that underlying root cause of stress and away from the symptoms in the body. So the attention helps to kind of take the pressure off those pathways and learning stress reduction techniques such as mindfulness, breathing, grounding. And then we've got emotional health, so understanding the link between emotions and the symptoms, and learning how to feel and express them in a safe way so that emotional events become less threatening. Then there's cognitive behavioural processes, looking at thoughts, beliefs, expectations that are contributing to maintaining symptoms, and also gradually reintroducing avoided behaviours using exposure techniques. And last but by no means least, lifestyle, which is obviously really important, and I'm sure I don't need to explain that too much to this audience. And there's lots of research on the effectiveness of these treatments, and I've linked to the bibliography page of the PPDA, which has an extensive list of research there. And one particular piece of research I'll mention is the Boulder back pain study. It was published last year in JAMA Psychiatry. And their key question was, can a psychological treatment based on the reappraisal of primary chronic back pain as due to non-dangerous central nervous system processes provide substantial and durable pain relief? And they took 150 patients and randomized them into usual care, open label placebo injection or PRT, which is pain reprocessing therapy. So they had one telehealth session with a physician, Dr. Schubiner, who made the diagnosis and gave some education, and then 8 psychological treatment sessions. And these were targeting a combination of cognitive, somatic, and exposure-based techniques to help patients reconceptualize their pain from this neural pathway perspective. And the results were pretty astounding. 66% were in the PRT group were pain-free or nearly pain-free post-treatment, compared with 20% in the placebo group and 10% in usual care. And as you can see, these results were largely maintained at 1 year follow-up. So pretty remarkable results. And clearly it was a small study and there were some other limitations, but it has prompted a lot of further research, which is really exciting. So lastly, I'm going to put forward some ideas about what can be done in a GP consultation to integrate these ideas. I think explicitly acknowledging stress and its impact on health, and I'm sure as stress is one of the pillars of lifestyle medicine that you're all quite good at doing this, so that's great. Discussing this with the patient using language that's normalizing and not marginalizing. And there's a really good guide about how to explain it to patients in the handout. Taking a stress history, so helping patients to understand where their unconscious stressors may be hiding, and for them to make those links between stress and their symptoms. And it also opens up the idea about that what has happened to someone is really important and it matters and that somebody cares. And then learning how to make a positive diagnosis of a mind-body illness. So look at the FIT criteria and the PPD self-screen in your handout, try out the questions, see if you can start spotting the patterns and use that information to help educate the patient that their symptoms may be more stress-induced than anything else. And the Howard Schubiner and Dave Clark both do really good training courses along these lines. It's really important is go slowly, don't push people, offer the information, plant the seeds and allow them to guide the process. Some people will jump at it and really take it on board. Other people don't want to hear about it, and that we have to accept that. You know, these symptoms have come of a lifetime of avoiding emotions and feeling a lot of fear. So clearly it doesn't look like a very attractive option to some people, and we just have to support people at whatever stage they're at. And give hope. A lot of these patients are heart sink patients. We don't know what to do with them. We get stuck. Actually looking at things through the perspective of the mind-body approach can really transform that. And there is a lot of hope to be offered to people if they're ready to take it on board. Recovery stories such as Fiona's can really help with that process. And lastly, signposting people to resources. And I've put a list of lots of examples of resources in the handout for you. So thank you very much for listening. Sorry, that was very fast. If you want to get in touch with me, then please do so. My contact details are in the handout, and I look forward to receiving your questions. Thank you.